to today's discussion, our expert conversation series on patient-centered care. My name is Andrew Phillip. I'm the Senior Director for Clinical and Population Health here at the Primary Care Development Corporation. And I am joined by our honored guest, Dr. Dr Blount, author of Patient-Centered Primary Care, Getting from Good to Great. And we'll be having an interactive virtual conversation today, talking about, of course, patient-centered care, but also having some kind of critical discussions about what this really means, how this relates to integrating services like primary care and behavioral health, and how we think about all of this within the realm of patients with multiple complex needs, but also the complexities of care teams who are working together to improve care, but also to keep their own work sustainable and possible. We're just trying to change our slides here. Okay, so a little bit about Dr. Blount. He actually coined the term integrated primary care and has been a leader in the field for over 35 years. Dr. Blount is a professor of clinical psychology at Antioch University, New England. He's also a professor emeritus of family medicine at the University of Massachusetts Medical School, where he founded the Center for Integrated Primary Care. And his online primary care behavioral health training program at the center has trained over 4,000 clinicians around the country and also around the world. His books include Integrated Primary Care, The Future of Medical and Mental Health Collaboration, and his newest book, Patient-Centered Primary Care, Getting from Good to Great, which just came out a couple of months ago, and we've actually got right here in our office. And so we'll be talking about that, but also some of his work as past editor of Family Systems in Health, published by the American Psychological Association. He's also the past president of the Collaborative Family Healthcare Association, a good friend to the Primary Care Development Corporation. So before we start our conversation, just a couple notes about PCDC, if this is your first time with us. Primary Care Development Corporation is a national nonprofit. We're a CDFI, or a community development financial institution, and our mission is really to catalyze excellence in primary care through strategic investments in primary care and behavioral health and other healthcare entities, as well as training, capacity building, and advocacy around policies that really enhance the presence of primary care for underrepresented and underserved communities, as well as other critical access points for care. And some of our claims to fame are that we've worked with thousands of organizations all over the country. We've invested over $1.2 billion into enhancing primary care around the country, here in New York in our headquarters and elsewhere, and created thousands of jobs in the process. And so part of what we do is try to also engage in thought leadership and bring in information from experts like Dr. Blount around the country to share with folks in our audiences in the healthcare sector. And we're pleased to offer this as a free resource to you. Everyone who's joining today will have access to this recorded webinar through our resources section at pcdc.org/resources. You'll also have access to a tool that Dr. Blount will discuss later, which is featured in his book. And you're welcome to share this with your colleagues and others. And we're pleased that you could join us today. So without further ado, I think we can hop right into it here. So Dr. Blount, welcome. Thank you for taking the time to join us today.
Thank you.
And glad you could be here.
I'm delighted to be here. What a great opportunity.
Thanks. And so I think actually a lot of our audience is probably familiar with you from some of your other work in the field. We recently got to hear some of your recent ideas and some information from your new book at the Collaborative Family Healthcare Association conference. And through some other discussions recently. So for some, you may be quite a familiar face. But let's jump right into it. So, obviously we're talking about patient-centered care. And I think this is a term that's been, it's been around for decades, but it's really been picking up in the last, what do you think, 10 years or so. And now it seems like just about everywhere I go, whether I'm talking to primary care, behavioral health staff, or pretty much anyone in medicine, this term is ubiquitous, and I don't even really know what it means anymore. So can we start with that? Tell us about where this came from, and when it comes down to it, what does it really look like now?
Well, I don't know who was the first person or a group to use the term patient-centered care. I know I have a pretty good idea of where it started to come into common parlance in the field. And that was around the time of the Institute of Medicine's watershed study called the Quality Chasm study, bridging the quality chasm in medicine. The study was as much focused on what was going wrong with medicine as what should be the next step. But after all of the what is going wrong, they addressed two aspects, I guess. One is how medicine is delivered and particularly in primary care. It's very much focused on primary care, but how primary care is organized to deliver care. And that came under the general idea of the medical home. And then how the relationship between the health professionals, particularly doctors, but the health professionals in general, and the patients should evolve, or what that should look like. And that was under the heading of patient-centered care. And as you know, those got combined into a model called the patient-centered medical home, which then became a model that was spread around the industry. Many practices have gone through a process to be designated a patient-centered medical home. They get paid extra in some states and some situations if they get that designation. But when this was first being launched in the mid-2000s, there was a big national implementation called the National Demonstration Project. Lots and lots of primary care sites in it, and lots of evaluation of how the whole process of patient-centered medical home was going. And so 5 years in, the evaluators came back and they looked at all these practices that had been working toward the medical home, patient-centered medical home. And what they found was that the medical home side had gone a lot better than the patient-centered side. They basically said all of these, they had 10 rules that they were offering for the future of medicine, and about 5 of them were about how you should deliver medicine, healthcare, access and data and management and quality improvement and so forth. And the others were how the relationship with the physicians or the doctors should go. And those were more about things like the patient should be the source of control in their own care. They should have unfettered access. These are in quotes from the Quality Chasm report. And so when they came back 5 years later and they looked at how things had gone, they said, well, this whole thing of becoming the medical home was really hard. It was, a lot of patients didn't like the process. Their satisfaction went down. The doctor's satisfaction went down, but it tended to come back up as they smooth things out. But with the patient-centered part, the change in relationship, they said, we really don't see much change. And so that piece, how do you create, ultimately they called it a partnership. How do you make patients partners in their own care is something that's still in front of most places to be done. It goes against a lot of the training that all of us have had. We weren't trained to have the patient be an authority on designing their own care. The idea of professionalism is that the best trained person in the room should be the one who takes the lead in designing care. And, you know, that would be a great idea. It sounds great, except in fact, the patient is the final arbiter of what care gets delivered. They either show up or they don't. They either take the medicine or they don't. So we can have all the authority we want in our training by telling them what to do, but the patient is the one who decides what treatments actually occur. And so the partnership step, while it makes good sense, goes against the training and the practice that most of us have had, and it is a real challenge.
Yeah, I mean, I think that's, and that makes sense. So it's, on the one hand, I think we can all appreciate that, you know, the patient is really ultimately where the care kind of stops and ends. We can't, you know, force folks to do things, and we have to kind of figure out, you know, what does the person in front of me really want, or what are they willing to do? But I think that is a hard topic for people to grapple with, right? Like I went to med school for, you know, a decade in residency, and you know, my patients come in with, gosh, diabetes, depression, hypertension, and you know, and chronic pain, and a host of other things. There's so much complexity here. How could my patient possibly know how to drive care or what to do? They need me, right?
Yes, that's exactly what makes logical sense to most professionals and what fits with their training. And they were trained in the, you know, when they go out to get evidence on diabetes, the evidence is done on the assumption that the patient takes the steps that are recommended. So so the evidence comes down that if you do exactly these steps, you'll be better off. Your diabetes would be managed better. And then comes the interface part where the person, and then we have this long list of things that can go wrong. We don't want to spend all our time on all the things that can go wrong, but the short list of I didn't understand, or I don't like being told what to do, or my family says that I shouldn't trust the doctor, or I can't afford this, or I can't get to the care. That kind of those factors become the real deciders for a lot of patients about what kind of care is delivered.
Yeah, absolutely. And so I want to get more into this idea of, okay, so then what? So how do we actually, you know, really make the patient at the center of care? But before we get there, I want to, there's a topic that I've heard you and read about you utilizing, and I think it's something that I hadn't been familiar with, but I'm curious if others have. The idea of multiply disadvantaged patients.
Yeah.
What is that? Is it different? Is this something different from kind of our usual, you know, complex patients? What does that mean, and kind of how does that fit in with all of this?
Well, that term was one I settled on in the process of writing this book. What I found was I was looking for who are the patients where it's hardest to make the partnership. And what do we have in terms of literature about them? And because my idea was, if I can offer a method that will help practices engage those patients and succeed with those patients, they will be likely to take me up on it, because those are the ones they're not doing well with, or they're doing the worst with. And those are also the sickest ones. And those are also the ones who are the most expensive to the healthcare system. So I found that there were three general literatures describing what I believe are the same group of patients. One is the literature on complex patients. So complex patients tend to be people with multiple chronic illnesses, often with behavioral health or substance abuse issues as well. Then there are the literature on disadvantaged patients. And this is the literature on people with low incomes, people who face cultural and racial issues and racism in their approach to trying to get care. And then the third group is the literature on people who are trauma survivors, and what it takes to engage folks who have been through that kind of terrible experience. And the ACEs studies have been where this has come into people's consciousness in a way that never was there before. So what I found was that the complex literature notices that most of the people who are complex tend to be low income. It correlates with income, and it correlates with groups, certain racial or ethnic groups, and that many of those folks are trauma survivors. But the complex patient complex patient literature doesn't then go and look at what's been learned in the low income or the disadvantaged patient literature or in the trauma survivor literature. And so I said, we need a term that brings these ideas together. And so the one that came to me was multiply disadvantaged patients. And so I make the case in the book about those folks. It's in a chapter called When the Doctor-Patient Relationship is a Chasm. And we look at not only the stresses that in these patients' lives, but their relationship with medical folks generally, and what's been learned about that in one or the other literatures. And one of the things been learned is that for many of these folks, when they get to see their doctor, instead of it feeling like a benevolent interaction in which a caring professional is trying to help them or care for them, what it feels like to them is an asymmetry of power. The doctor has all the power. I don't have any power. I have to do what they're told, or I can decide not to do what they're told if I want to have some power in my own life. But that sense of, for many of these folks in some small studies that I saw, what I found was that people who are multiply disadvantaged patients who have trauma histories get re-triggered just by going to the doctor, by being in a situation in which they have no control, in which they're told what to do. They gradually become more and more passive, more and more estranged from taking care of themselves. And so they leave feeling violated sometimes. And it's not about the intimacy of the exam. It's about this whole situation of the way medical care is delivered. And so that sense of how big a gulf is there, I felt like really needed to be underlined, because when in my 15 years of training family medicine residents, I would say to them, I saw this all the time. And I would say to them, do you understand how alienated or disaffected some of your patients are? How much they think the doctors are all in it together and they're just out to make money and they just want to take advantage of me and that kind of thing. And the family medicine residents thought I was exaggerating. They thought this could not be, because they knew their hearts, and their hearts were benevolent. Their hearts were, we want to help folks. And so the difference in the experience of the two people in the room is so profound. Even when you add behavioral health, you get a big leg up, because now these complex folks, these multiply disadvantaged folks, have significant behavioral health needs. So you can address more of their needs. And that can be a piece of engaging them. But there's also the sense that they aren't ready to be partners. And in order for them to be partners in their own care, we're going to need to find a way to help them feel that they have the wherewithal, that they have not just the empowerment, but the self-efficacy to do this, because mostly they don't feel they have much self-efficacy in terms of their life and their health, as well as in terms of their relationship with their doctors.
Yeah, I imagine that resonates with a lot of us. I mean, even as you're talking, you know, in my time as a psychologist in primary care, that having that kind of extra set of eyes, I heard that a lot myself, where, you know, I had a great team of physicians and nurse practitioners I work with. And, you know, again, like really wonderful, you know, the heart's in the right place. And just somehow, despite that, I would sometimes have patients who would come in just after having, you know, an exam or something like that, and tell me about what a sort of alienating experience it was, or even, like you said, just the entire system. So I want to get into, again, like this kind of then what. I also want to just put a pin that as folks are listening in, we're going to have time in a few minutes to hear questions from those of you in the audience, or hear your experiences too. So if this resonates with you, you can use the chat box to the right of your screen there, and we'll get to your questions and comments in just a few minutes. But so, okay, so let's say I'm here. You know, I am a well-intentioned physician. I'm seeing patients, you know, in my clinic, or, you know, a behavioral health provider, whomever. How do I know when I have a multiply disadvantaged person in front of me? Like, what is there a way to know? Should I assume everyone is? What's the sort of the trigger to know, okay, I should be maybe doing something different, or is that even the way to think about it?
Well, what I would propose in the long run is that if you get good at addressing or helping, making partnership with your multiply disadvantaged patients, you're going to have to use methods that you're going to like so much. You're going to use them with everybody. But I couldn't sell you on using these with everybody, because everybody isn't giving you a problem. So we'll just focus for now on multiply disadvantaged folks. And multiply disadvantaged folks are describable in three general ways, right? They're multiple complex illnesses. They tend to be low income, possibly minority, though not required, that isn't inevitable. And they often, if you give them an ACEs screen or some other way, you would discover they also have a history of trauma. And so what it allows you to do is to say, if I have somebody who is a low-income person, they seem to have low health literacy, and I'm not doing, when I give them directions and show them what they might do, it's not working very well, you can just say, okay, we don't have to keep looking at all these other elements, let's just start doing it this way. Of course, the other thing I'm going to suggest in the method that I'm showing is that there are going to be things that you need to do for this population that's going to require you to change how you do with all of your patients. Some of what I'm going to describe are things that you would only need to do with these folks, like the patient-centered care plan, at least for now, but things like being transparent and patients having access to their records and so forth, that's going to be something that is practice-wide. So each of these is going to be a part of a whole practice effort, not something where you say, okay, I've got one of them here, and so I'm going to do this little thing, but I'm not going to do that for anybody else. Because as you get better at working with these folks, you'll be working in a team. You'll be having a more enfranchised group of people around you. You, as the physician or clinician, are going to be carrying less on your shoulders and have more real colleagues on the team. And so because we have to do that, we're burning out doctors very fast. And so one of the things that the National Demonstration Project evaluators said is doctors need new mental models of care in order to do this right. And I'm thinking, we put everything that we need done in the health system in general on primary care. Yeah. And so, you know, you have to do all of the screening that we think any particular population needs. We can't go to specialty care, that we're going to have to screen it in primary care. They need to see more people. They need, if we, in a state, for instance, now we have 700,000 new people because we've expanded Medicaid. We don't have the appropriate number of new doctors, so the doctors we have should just take up the slack. That kind of pressure is already terrible in primary care. And so to say, and you also need new mental models of care is, I would think, is a non-starter for an awful lot of docs. So we're going to need a team. Of course, they also said to do team right, you need new mental models, because you've been trained to be responsible for everything. And you've been trained to be the leader of what really actually is a squad, where the one leader, one focus, as opposed to a team where multiple leaders in multiple situations might arise depending on the need of a particular patient or a particular situation. So all of that is, you know, I do a lot more in detail. But so that when you have a team that's high functioning, you have a team that has enough time to meet. That's another piece that makes the team work, is that you have enough time to meet. And the last piece is, and you have a consistency of team members. You don't have people, oh, I'm on this shift today, I'm on that team the other day. That they work together, and the more they work together, what one author called consistent team structure, the better team culture develops. And the more team culture develops, the more physicians and staff like their work, don't burn out. The literature on high functioning teams says that high functioning teams are associated with increased provider and patient satisfaction, lower error rates, better communication with patients, better adherence by patients, and better health outcomes. So one of the things we're gonna do is we're gonna have more eyes, more expertise sets on this team, and more sharing and time to do that.
Yeah, I know, and that's, I think you're right. In a way, you're sort of describing both the kind of the way to be successful and to kind of, you know, share the experience of caring for and partnering with patients, but also, man, there's a lot of complexity to this. And, you know, earlier you mentioned screening, yes, and other things that we have to do also. But speaking of teams, you know, I know you've talked about a capital TEAM way of sort of doing things more effectively. Let's talk about that and kind of get into some of that. Okay, so, you know, now what do we do with this?
In working with the ideas to, you know, we have the different descriptions of these patients. I looked at what is the kind of care that it takes to do trauma-informed care. And I used that as a way of sort of structuring the approach that I came to, the mnemonic that I came to. And if you look at the trauma-informed care, they're going to say it has to be safe. And safe isn't that the patient isn't going to get hurt. Safe is that the patient experiences it as safe. It has to be transparent and trustworthy. Patients have to have access to all the information about their care. Of course, that's what the IOM said 20 years ago. They have to have meaningful choice about the goals of their care. They need collaboration and mutuality, shared decision-making in pursuing those goals, and they need empowerment. And empowerment in trauma-informed care isn't a political word. It means interactions that focus on the patient's strengths and the patient's successes as much as possible. That people have to be defined as folks who and they have to experience themselves as folks who can care for and take care of their health by focusing on what they've done right and what they have succeeded in the past. So I came up with the mnemonic, and the mnemonic is T is transparent, E is empowering, A is activating, and M is mutual. In fact, if it's hard to go back through them, I would, first of all, transparent in the sense of people having access to their own records. That in fact is coming. There are over 41 million people in the country right now who can go on their patient portal and click in and see the actual notes their doctors write about them. And that is spreading every day. And if you go to a place called opennotes.org, they've got a counter there that shows how many patients now have open notes. When they were doing the studies for this open notes approach, one of the things they found was that if you taught multiply disadvantaged patients how to get to their record through their cell phone, they used it more than their more advantaged colleagues. They were helped more by it. They reported that they understood their medical condition better, but that the thing they really were struck by is how benevolent and caring the doctor's notes were compared to what they expected. It began to make them more trusting of the doctors they worked with. And so they were the ones who were best affected by it. So if we take this transparency that's coming in terms of access and we make it something that we're gonna do, we're gonna teach people to use it. The other thing is that if you're gonna have your notes read, you probably need to not change the facts are the facts, but change the language you use. And so, there's a lot of language that's professional language that is experienced as insulting language by non-professionals. A good example, the word obesity is a technical word in medicine. On the street, it is not a technical word, it's an insult. And so when you get this note that says 34-year-old obese woman comes today, when she reads that, she's going to feel very insulted. On the other hand, if you say Mary Smith is 34 years old, she struggles to manage her type 2 diabetes and to control her weight. Same facts. Now it's a very different experience for Mary Smith. And so that beginning to change or evolve your language, reframe a bit how you use language. And then lastly, if you get good at that, we can stop having conversations about patients in the hall and bring it into the room of the patient. Now the patient's standing there, they're on the team. And so when the doctor is telling the behavioral health person about I would like you to work with this person, they can describe that person in a way that makes the patient feel connected, feel like they really are on the team. And that becomes a way, a habit. It's like building a muscle. Speaking in front of the patient makes you use language in a certain way until the more you do it, the more it's just natural. You don't even think about it.
Yeah,
so,
sorry. I mean, there's a whole phenomenology, I think, around this of how we write about people, even
right.
What prompts come up in the electronic health record that seem to really change our behavior and the way we always talk to our patients about the importance of words and kind of like the
right.
language we use. And I think that's a great point. But it sounds like it's something that doesn't just, I imagine for a lot of folks who have been practicing, it doesn't just, changing the way we document, changing the way we kind of label people that we're working with, that doesn't just kind of happen, right?
You have to be committed to it. Yeah. It takes a real determination. One of the things that helps me do that, and I've done it now for 20 years, is when I see somebody for the second or following visit, I read them the note from the previous visit. So it means that instead of writing notes that might someday be able to be read by the patient, I write notes that I know darn well the patient is going to read, and because I'm going to read it to him. And so when you get used to writing that, that sort of keeps those muscles strong, and it becomes easy. It becomes, and you can say very hard things. So your patient comes in, they're drinking again. You can say, Joe has been struggling with alcohol for a long time. Lately, he has been much more sober than off the wagon. Temporarily, he's off the wagon. But if his history, recent history proves true, he should be sober again in not too long. That's a absolutely factual statement about this guy rather than drinking again.
And that idea of reading the notes to the patients right then and there, I can't think of a better way to change our own behavior than being in that situation.
You think about them different.
Yeah.
It makes your brain change. And so you end up working with less frustrating people because you've talked about them in ways that not only make them less frustrating because of how you define them, but when they hear it, it brings out their least frustrating part. They like it. They want to engage. It gives them hope. And so it's a powerful clinical tool. It's not just documentation. So if you go on from speaking of empowering, if you take that transparency and you add the kind of empowering that we talked about in patients in trauma-informed care, looking at successes, I like to use solution-focused interviewing, not therapy, but interviewing as a way of helping connect with people, particularly rather than a whole solution-focused approach. I particularly look at exceptions and I look at coping. One of the things I find very useful is asking people about the problems that didn't happen. The person has cut down from 10 cigarettes to 5 cigarettes and they come in, and instead of just working on the next 5, I'm going to ask them about the 5 they didn't smoke. When did they think about it? What went through their mind that kept them from doing that? Did they notice enough to make them a little proud that they were able to avoid those cigarettes? I'm going to focus on the ones they got right as the foundation for the next step. And when you do that, in the book, I go into the actual neuroscience of this, that if you are in one, I want to say folder, but folder is a terrible metaphor for neuroscience. But if you're in one experience, and that's your emotional and cognitive sort of guide or moment, your history and your memory fits that. And so if you come in and say everything's terrible, you will have a whole history of things going all the way back that come up to today that explain today. It's terrible. If on the other hand, I can get you through 10 or 15 minutes talking about exceptions or about the bad things that didn't happen, and you start to feel like, yeah, I can do something, all of a sudden you start remembering all the other things you could do. And so people get access to things that before, cognitively, they didn't have access to. And so this is an intervention in terms of their own access to their own resources. So empowering language helps them notice the things that they get better, things that they do right. And then you go to activating language, which is essentially attributing the ability to take the next step and be committed to their health to people, because attributions are very powerful influencers. And if you just had a bit of solution-focused talk on how they got that right, you then build an attribution on top of that. You're someone who cares about your health, And that then becomes something that they begin to believe, they begin to and enact. And so I created this little thing. It's sort of silly, but it's sort of not silly, called the attribution generator. This is just an example. This is not the only things to say, but these are things that are generally useful. So you just take one from column A, one from column B, and one from column C. One of the things you'll notice is that all of the ones in column A are tentative. None of it is, I know this about you. That is a dominant patriarchal talk or thing to say to somebody. On the other hand, if I say, you know, it looks to me like you're learning to prevent health problems down the road. Does that sound right to you? People say, yeah, you know, I really am. And so if the person for some reason says, no, that's not true about me, you drop it. It's not a big deal. It's gone. But mostly, since you're particularly building this on something that you just said in a solution kind of way that they have agreed to, is something they did. So you know, I may be wrong, but I'm thinking you're getting more confident that you can maintain the lifestyle changes you've made. Does that sound right to you? So you could fill in other things here. And these are generally attributions about being committed to your health, because that's what makes good patients in doctors' eyes. And so the person then is more committed to their health, and the doctor sees them as more committed to their health. And now we're talking teamwork. Now we're talking partnership. So that step, then the activation step, begins to give people the self-efficacy to actually be partners with their doc. And then the last one is mutual. And mutual is built off the notion or the practice that I have learned from using it and from colleagues that I've talked to of the patient-centered care plan, bringing the patient in on actually doing the care plan that's going to be the care plan throughout the whole health system, not just is going to be for today or just here in this practice. And in the book, I give examples of it, and it's been done in Washington State and in Oregon and in Massachusetts and in New Hampshire and a bunch of different places. And it's still in practice in a few places. The general experience is going through the creation of this care plan is a healing experience for the patient and the provider. In New Hampshire, they said we used to do this practice with the patients that we were most frustrated with, and we liked them so much better at the end, but they liked us so much better. The issue will then be so that when the patient goes somewhere else in the health system, that person who opens their file in the EMR sees that care plan, understands how important it was to the patient to make it. So this is not something you do in 5 minutes. It can take anywhere from an hour to a multiple or a couple of visits, not multiple visits. But sometimes the care manager can kind of navigate it along. But if you do it for your multiply disadvantaged patients first, for your highest utilizers, for the people who are most frustrating or most difficult, you may spread it beyond, or you may not, but people will find it very useful, I think. And so that's the TEAM way that I think people are going to learn over time. It's more of a transition in thinking and in practice together with a steady team, with a consistent team that has time to talk. By the way, in some health systems, the amount of team time has been changed dramatically because they have seen its impact on patient outcome and on provider retention. And though, you know, people tend to keep team time to a minimum because you got to go see the patients, you got to earn money, you got to see the most folks. When they get past that and commit to the team organizationally, it has made a real difference in their organization and in the morale of everybody, patients and staff.
Yeah, I know that making time for communication, even just within the care team with patients in general, has been frustratingly slow to, you know, I mean, we're starting to see codes coming out and things that kind of allow for that, systems who are making upfront investment there. But I know that's been a pain point for a lot of people. But I mean, overall, I like it. It's interesting as you're talking about the TEAM kind of steps. I see how it makes sense how, you know, earlier we started talking about, well, you know, there's been this kind of frustration when we're really making the patient not only the center, but the kind of the driver, the leader of their care. Yet they have so many, you know, like you said, not just complex, but complicated and multiple issues. These are ways, it sounds like, that we empower them to really be that leader. And so we're not just asking them to come in and
That's
just
right.
take it away.
Our own partners.
Yeah,
in the process. Yeah, and I'm being asked by practices to come and do training on this method, and I do, and I'm going to develop more that will be available in the future. But the other piece is, it's not just a training thing. It's not like we're going to have a day long and then after that it'll be all set, because to do the transparency piece, to do the team piece, this is administration at the very top that has to be part of this, to have to be supporting, that have to look at the evidence that that I present carefully in the book. Otherwise, they're not going to go there. Oh, yeah. And so this is going to be a little something that people will help them in their practice, but it won't get them to the full advantage of the approach.
Yeah. Yeah, I mean, talk about, you know, primary care teams feeling like they're sort of the testing grounds for every new thing that comes out. Man, if you don't have that really high level, you know, C-suite and down support, we see the same things in our own PCMH work and in our care management work. It's ubiquitous. I have more questions for you, but I'm being a little bit of a hog here, so I'm going to refer to a couple of the questions that have been coming in as we've been speaking. And this is a great one. I like this one a lot. So, you know, talking about, you know, multiple challenges and complexities in working with our patient populations, what's your opinion on the pros and cons of screening all patients for social determinants of health, things like food insecurity, transportation, finances, and trauma? I know you mentioned ACEs earlier. Is there any reason not to ask these questions of all patients versus just the ones, like you said, those ones that maybe we have kind of a suspicion that there's something else going on with?
We screen all patients for behavioral health. We don't do them every time they can't come. You know, once a year we do it. And so asking about the social determinants of health, I think, makes a lot of sense. It doesn't mean that you would do that all the time. You would do it once or once a year, I think, but no, you definitely want to know. One of the things that's basic to screening, however, is you don't want to screen for something that you can't offer anything about. And so screening for social determinants of health would be something I would institute after I had care management or community health workers or someone, I call them care enhancers, on the team. Excuse me, I'm getting this light on me. On the team, so that I had some shot at least doing some standard sort of fixes and some standard sort of connections with people and helping people with paperwork and so forth. But yes, I think you should. The issue of screening for ACEs, again, you want to know what to do. And screening for ACEs is not screening for PTSD, which is a different screen. In our practice, we screen for PTSD. We said, well, we'll look for symptoms because those are symptoms that we can and should address. The question of what do you do if someone has a traumatic history is more complex. What if you find someone has a terribly traumatic history and you are treating them like a person who is functioning fine because they were a person who was functioning fine? Do you then want to say, oh, trauma victim, oh, we have to change things. Oh, I'm so glad you're here. I know you've been through so much. That's not a positive change for that person. And so when you, and the idea that all these people need therapy is wrong, is not something that you would have as an inevitable thing. In fact, the recommendations from Felitti and others who have done this is that the question when you have someone with, a 5 or, big high ACEs score, the question is not, tell me the story of what happened. The question is, I see that you have been through some terrible times. How has that affected your subsequent life? And how do you cope now? So it's about coping. And on the other hand, you have to be aware that the ACEs is a good way for many people to tell the story about what they've been through because it's so nonspecific. Doesn't take them through the actual memory of what happened necessarily. And so in one study of high utilizing folks, they gave them all the ACEs. They had no idea what to do then. They just gave them the ACEs. And what they found was in the next year, those people utilized less. They came to primary care more. They had fewer ED uses. They essentially, and when they interviewed them, they said, yeah, I felt like somebody knew what I'd been through. That was good. Somebody knew me. So it's a complex area. I don't know.
I mean, I think what you're highlighting is, I mean, that's, we do a lot of training with, care managers, community health workers, and
right.
physicians and others. And that is, I think, such a stressful and complicated pain point of, do we ask the questions when we don't have the tools to do something about it? Do we know if we even need to develop something to do about it if we haven't even started asking the questions yet? It's quite I know we're on a lot of the same listservs here, and these come up every couple of months, but I want to keep taking us through. We have about 5 more minutes, and I've got at least a couple more questions. This one is really, really timely. So this individual's asking about folks who have chronic pain conditions, and it's been, I assume we're all kind of floating in this and the opioid epidemic, and it's been just what a mess. And so when we have folks who have been, through whether like a protocol was interpreted this way, or it was a clinic or hospital mandate that they go through these really rapid tapers, and it causes all sorts of issues. These are multiply disadvantaged patients often. How do you see those folks fitting in? Is there any special considerations there?
Well, they were certainly part of the group I was talking about, at least many of them. Substance abuse and trauma correlate, substance abuse and so complex illnesses correlate. So I think I've been talking about them right along. On the issue of how do you help them when the system around you is doing the wrong thing and going against the evidence, I don't have the one right answer for that. The idea, if you look at what the folks who are at the forefront of medically assisted treatment and the behavioral health side of that and so forth, are saying now they are saying you do not treat buprenorphine in the same way that you treat your other controlled substances.
Right.
That when you have a stimulant, when you have a pain pill, when you have a benzodiazepine, you are watching that it doesn't get out of hand, it doesn't go too far. When you have buprenorphine, the default position is to prescribe. And given all of the complexities, the default position is to prescribe. And so that I can't be the one to turn that around. I don't have the cred to do it, as we say. But I think being informed is very helpful. There's an article by Steve Martin and other people that came out last year on opioid and medically assisted treatment. That's sort of the current state of the art. And so if you can go find Stephen Martin's article on MAT, that's a good place to start.
Yeah. And I agree. I think actually the folks with chronic pain are probably some of the best ones to apply that team kind of method to, and
yes,
have the visibility of the charge. They've been alienated for oftentimes years by the time they're really getting services. But I'm gonna and we could have a whole other discussion on that. We've got like 2 more minutes left. I want to get to one more question here. I think this is also important. This person's asking about building team cohesion. Obviously time helps. The longer you've worked with people,
yep.
Have team meetings, but what else would you suggest?
What else I would suggest is appreciative inquiry.
Yeah.
Appreciative inquiry is essentially the name of the techniques in solution-focused inquiry only used in an organization. And they claim, the appreciative inquiry people claim that they developed their approach separate from and not related to solution-focused interviewing. But I'm telling you, if you look at both of them, you know that, I don't know what happened, but they mutually influenced each other. But it allows you to say to your colleague instead of just your patient, what you did there was so helpful. Let me tell you, and when you describe what they did, you tell them exactly what they did and why it kept things from being worse and why it was a great example. And that even if they don't do it all the time, you saw them doing it then. And so that appreciating of your colleagues with very specific descriptions of the things they did that you appreciate, and the sort of sharing of that as part of your team time, that you would have once in a while this time to say, we're gonna go around and highlight what various team members have done that have been particularly helpful to other team members in the next 20 minutes or so. That is a powerful intervention.
So we are at the top of the hour here, so I'm gonna start to kind of close out our conversation. But there's more questions coming in. I'm gonna put up your contact information here in just a moment. And again, we'll have this entire recorded presentation available for everyone. Probably.
Do you have my contact information available?
I'm having trouble advancing the slide here. So one moment here, we'll get everything up. So we have your contact information. Of course, ours here at PCDC, right. And then your attribution generator tool will also be available, and we'll send out the link for folks.
It looks like it's frozen.
Who've registered here. So we're having a little technical problem getting to the next slide, but we'll send it out via email to everyone who's joined today, right. Along with a copy of today's slides, as well as, there we go. All right. So we've got your information there.
Yeah.
And again, this is recorded. It's available free to anyone who's interested. We'll send out to everyone who's registered and attended today the information. So Dr. Blount, thank you very much for sharing your insights with us and really promoting this idea of not only, talking about patient-centered care, but actually doing something about it to really empower our patients to move their care forward.
Thank you so much for the opportunity.
Yeah. And thank you everyone who attended today, and those of you who submitted questions, and we look forward to continuing the conversation. So keep in touch.
All right.